and just the glucometer, we are able to diagnose diabetes. We always ask if this type 1 is this type 2. How do you make that distinction? You can't do it just using glucose. Okay? So we are saying it's time we have to look at that to make sure that at first level hospital they can make that diagnosis and attend to the patient more appropriately. And the third one is to enhance capacities of staff. Okay, this is where now training comes in, but also we want to have available treatment protocols to standardize treatment. Okay, we need to have treatment protocols. It's very, very important because you know what has been happening at primary care. Someone comes with hypertension today, you only have another pill in stock, so you give him another pill. Tomorrow he comes back, the blood pressure has gone higher. Someone says, oh no, you can't use another pill here, use amlodipine. He cancels that, uses amlodipine. Okay? The following day he comes, oh no, this one you don't use amlodipine here, cancels amlodipine, gives furosemide. Right now, there's no way of us saying he was wrong, he was right. Okay? But we hope that we are going to have these treatment protocols. That is why I'm calling on you colleagues to fully participate in this process. Because these protocols must be evidence-based. And for me, the best evidence is from your own practices. Not all in Kenya, they have said that, this drug works very well, so we are going to use it in Zambia. No. You should be able to say, I use this drug, and my patients have very good outcomes. I use this drug, and the doctor gives me side effects, and people don't like it. So we can move on to something else. But these will be very, very nicely guided protocols. Okay? And we are hoping that by that route, we are able to say, this is the way we treat this disease in Zambia. So if you come with diabetes at Matero Clinic, this is what the clinical officer will do when you are there for the first time. If your blood pressure is not controlled, this is the next thing that's going to do, and this is the next thing he has going to do. So that, we can hold each other accountable. If someone did something wrong, we're able to say, this is malpractice. Why? Because this is not the expected practice. Okay? And then the fourth one, okay, Dr. Girenda has come out. Okay, to strengthen capacities for patient-centered services. Okay? We want this thing going to the community. The patient must be center of our treatment, and he must be part of the treatment team. And then the community must actually provide all that is necessary to improve adherence to these treatments. So what is being done in the HIV world is being emulated here. And that is why it's good to have you, Dr. Seville, here, because really we have to integrate. Those systems which have worked very well for HIV care can also work very well for NCD care. And we are hoping that, together we are going to win this battle. I just wanted to bring out the 4x4 matrix. I think people have talked about 4x4. 4x4 of what? Okay? Our friends have insisted on these 4 NCDs, the things that we call Big 4. Okay? Heart disease and stroke, diabetes, cancer, and chronic lung diseases. With their 4 risk factors, main risk factors: tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol. But as I said, for us, we are going beyond those 4, okay? Because we know that there are a lot more NCDs on that list and a lot more risk factors. And most of those risk factors are hiding under the poverty curtain. So really, we need to get into the communities. And that is where things happen. That is why it's good to target primary care level. Primary care, we are very close to the community, and we should be able to use community structures to get things going and get things really done well. Now, one of the journalists was talking to me about United Nations, about African Union meeting next week. Now, the African Union has a very strong health portfolio. And through the years, they have said a lot of things about improving healthcare in their different countries. Okay? One of the declarations that we always refer to from from the AU is the Ouagadougou Declaration, which targeted non-communicable diseases and how they can be looked at within the communities. And then we have the whole manual they are talking about NCD management at primary health care level. And so we need to move towards responding appropriately to the NCD epidemic. Okay? Or now I think we are more used to the word pandemic. So we should say the NCD pandemic. Okay? We need to move from individual disease programs to integrated programs. That is why we are talking here of moving into the NCD arena. We need to move more into pediatrics as well to look after children. And then this clinic, as you will note, Dr. Busudu, is one clinic which brings together pediatrics and adults. So a health care worker in the Pain Plus clinic should be able to attend to a sickle cell disease patient who is 2 years old, and then attend to this patient who has chronic heart failure at 80. Okay? So the training of these health workers is going to be intense, but it must be well done. We are not going to take any shortcuts. Okay? And then obviously we need to strengthen the healthcare system so that we not only move towards control, but that we can prevent NCDs. And when you talk prevention, we are talking of community level action here. Then we need to promote the common risk factors approach. We need to look at the risk factors and actually move towards promoting control of the risk factors. And then we need to really address partners within and outside the health sector to address the externals of non-communicable diseases. It's very, very important. Okay? And we'll do that well by putting limited resources. We need to put everything together. We don't have to say, no, this money is for COVID. And so those of you without COVID, you are out. This money is for ARVs. Okay? Those of you without HIV, you are out. I don't think that's the way to go. Okay? And one thing, as we have said, is not only to be looking down. Pain Plus, as we say, is targeted at the bottom billion, the poorest in our communities. It's here where things are happening. And this is where we need to be operating. How well we work there to make sure that things are well done. So, those are the main objectives of the Pain Plus project. It will actually be done in phases. Okay? This project has 4 phases, but this phase 1 is the most intense, and it's the one that is going to involve your people on the consultative group most. After phase 1, it will just be monitoring to make sure that what you have recommended is being done. But in phase 1, we need to set standards. We need to set standards, and we need to do all that is required really for us to adapt the Pain Plus to the Zambia primary service delivery system. Okay? So the first thing we need to do is to define the care delivery package. Okay? What's the delivery care package? Sickle cell disease. How do we care for sickle cell disease? We need to define it nicely so that a nurse or a clinical officer can follow those guidelines at primary care level and look after a sickler very well. Hypertension. How do we adapt hypertension? Okay, what's the ultimate delivery care package? Okay, and then as we move forward, so as we define the care package, we will not only be putting out guidelines and protocols, but we will also be advising on the tools that are required. What are the diagnostics required at this level for management of this condition? What are the drugs required for management at this level? So all this must be done, and it will be done by the stakeholder consultative group. Okay? Then we need to evaluate the implementation process. Okay? But this will be done through real-time monitoring and evaluation, meaning that as the project goes on, we ought to be on board. We ought to see what is happening going forward. Okay? In 1.2, I think here we are really talking of support system actors. We need to actually know who these are and how well we are going to work with them. Okay? So there will be training here of frontline health workers, clinical officers, licentiates, nurses, community health assistants, and community health workers. Okay? They all ought to be brought on board. Okay? We train them, and after training them, we mentor them. So some of you who are sitting on the consultation group may be requested to actually participate in the mentorship process. And then we also ought to engage new people when it comes to getting into the community, so to say. We want to put out messages for education, okay? So we want to educate health workers, and we also want to educate patients. So we need to have posters put out, okay? Posters for patients to know what is required of them, but also protocols, algorithms, nicely drawn out for someone to easily follow at that level. So the consultative group needs to help with these processes, okay? To make sure that they are targeted and they are achieving what we want them to do. In phase 2, we will actually work now at piloting all what we have developed in phase 1, and we will pilot those issues in 2 phase level hospitals. So we are starting with Matero level 1 in Lusaka and Machishombola, which is Kibongo District Hospital in Kibongo. So we are hoping to operationalize the clinics there, and once the clinics start running, we'll be using them as demonstration zones. So in 2.2, we will make those places as training centers. And in phase 3, we actually need to work now on the national operational plan. We want the Ministry of Health to adopt this as a normal way of doing things. Okay? How do we look after NCDs in Zambia? We hope that that can become a policy or a policy document that can then be implemented in all first level hospitals. Then we can move on to do the national scale up of Pain Plus. So in the letters that we wrote to you, I think we did detail these things which are here as to what is expected of you. Okay? First of all, we are expecting all of you to seriously take care of your portfolios. Okay? Meaning that you each must be a bit selfish about your space. That is why when Dr. Sika you will take care of it, okay? And it's a big project because we have rheumatic heart disease, we also have sickle cell disease, and Okay, or the pediatric neurologist will also address adult neurology. Okay, and so everyone must actually be understand. Okay, so what we have done, okay, is to establish baseline of service availability. So the first meeting we are going to have, we will bring to you what is obtained at these hospitals. Okay, are they able to do HbA1c? Are they able to do C-peptide? Okay, are they able to do survival cancer screening? Are they able to do breast cancer screening? We will bring you that baseline. Okay? But what we want you to do, okay, is to help us identify the gap. Okay? Identifying this gap, meaning that you will actually advise us on what the ideal is for these conditions. Meaning that we want to, for each condition, we want to have a definition of ultimate best care that can be given to that person with that condition. What's the best care? Okay? So if one comes to this hospital with diabetes, what is the best care that we can give to that person? Right now, then you tell us this is the gap, guys, which needs to be filled in. Okay, so if the diabetic person says for diagnosis of diabetes, the minimum I accept is HbA1c. And then HbA1c is not there, we will make sure we put it in the hospital and monitor how it works. If it works very well, then we will advise that should be standard care going forward. Okay. But we need to do that. That is why we cannot do all the 54 conditions. See the thing? We cannot do all the 54. We don't have the time and we don't have the resources. So what we will do is try and work at prioritization of those priority conditions. So the 54 are already priority. But of those 54 conditions, we want to take the top 10. Okay? What are the top 10 conditions? And then once we know the top 10 conditions, we do that exercise. What is most important is actually defining this idea. For each condition, for each of those 10, what is the idea? Okay? We need to know that, then we need to work towards plugging the gap between what is obtaining now and that idea. Then we also need you to help us define referral chain. Well, I'm calling it redefining here, because what is happening now is like, for heart failure patients. Heart failure patients are treated admitted at Matero, but because they don't have a physician there, they refer them to UTH. The UTH people sort out the heart failure. They send the person back to Matero, but he must come back to UTH for review. Now, is that necessary? The answer is no. Once UTH have sorted him out, he should be reviewed at Matero, but reviewed by a competent health worker. Okay? So that is what we want to do. Okay? That's why we say, can we redefine referral chain? I know last time it was tried, but it was really, I don't know what you want to call it, where they just say now, decongest UTH. Okay? Heart failure patients from Matero, send them to Matero. Heart failure patients from Challenge, send them to Challenge. And the patients who have Challenge clinic, we have been told to come here for review. And the doctors there said, us reviewing you. No, you are a UTH patient. You are beyond us. So you go back to UTH. And within 2 months, they were all back at UTH. Okay? So we must find a way of doing this referral and reverse referral to make sure that people there can take care of what is capable. When they run into problems, they refer. But it's very clear, so that when a patient comes to UTH, we know why he has come. Not that they were not able to handle it at a lower level. Okay? So we need to take time to define this care delivery package. Okay? And then we'll move to implementing that care delivery package. Okay? Then, as I said, we need to follow through to make sure that right things are happening. And then you will need to help us do these other things. Okay? The record system, I already mentioned about smart care, that we really want to have an automated record system, a system that can take all our information, and a system that is also easily accessible, so that we can see which way we are going. Okay? These hypertension patients, are we winning? Right now, we are saying, elsewhere in the world, they are saying 30%, only 30% of people know that they are hypertensive. Of those, only 50% are on treatment. Of those, only 50% are controlled. But in Zambia, the figures are really of those, only 15% were controlled. Which means that there are some people who are following tablets, but the tablets are of no good to them. They are not bringing down their blood pressures. But right now, it's very difficult to know which patient is doing well and which patient is doing bad. Okay? So, just as NRT guys are moving towards 90. We want every other disease to move towards that end. Okay? Especially as in the hypertension world, we want 90% of adults to know their blood pressure. Those who have hypertension, 90% of them should be on treatment. And those on treatment, 90% of them should be suppressed. Same principles. Okay? And get them, we ought to use the same system that our friends are using. Okay? We need to persuade them to get their BPs measured. We need to persuade them to swallow their tablets. And we need to monitor how tablets are doing periodically. So the same principles that are applying there should be applied to NCDs as well. Okay? So we want this record system to be well done. Okay? And then involved in all about publishing people. Once we start treating rheumatic heart disease patients, we want to publish on rheumatic heart disease. Okay? Once we start doing diabetes, we want to publish on diabetes. And to see that the project will actually be just me and the people responsible for putting that information together and publishing will be you people on the consultation. So please put on your academic hats and let us pull out the information from these centers and let us share that information with our friends. We are obviously sharing that information so that it can translate into some action. Either it influences policy or it influences clinical practice. Okay? So we move towards there. We want you on board for that. Okay? Then I've already talked about this messaging, that we need to have messages sent out to patients. We want to help them, and we want here to actually bring out messages to the health workers about, especially about outcomes. We must show them where they are doing well and where they are not doing so well. And then, with time, we need to actually find consensus on main issues, okay, involving priority NCDs, to ensure that there is quality in our service provision, but also that there is acceptability, feasibility, and affordability. You need to move towards there. A few years ago, we were arguing with our friends from infectious diseases about treatment of TB. Okay? No, let us move now from isoniazid. The reason was cost. He said, but is this a good reason for moving from one drug to another? What about us in the private sector? Can you leave us alone? Can we continue with the pharmacy? You know? And the Ministry of Health guys were very, very hard. They said, no, whether you're in the private sector or the government sector, or move away from the pharmacy. A few years later, we were back to using the pharmacy. Said, but why did we move that way? Okay? It was all power. But here we are saying it's not about power, it's about consensus. So the consultation group needs to move towards setting consensus. So as you sit on this group, we will not be considering that you are a director, if you move to somewhere, you are a professor, if you move to somewhere. We sit on this consultative group as practitioners, and we need to listen to each other, we need to advise each other, but really we need to make sure that we are agreeing. Is it quality that we are bringing up? Is it an acceptable practice? Okay? Is it feasible? Meaning, can it be scaled up to the rest of this country? And is it affordable? Okay? So the consultation group, you have quite an amount of work here, but I'm hoping that through this, you're actually seeing that we need you and that you need to spare time for this particular function. Okay? Then we have the project management team. Project management team is the one that is on the ground. I'll be leading the project management team, helped by Will Mutale and also Dr. Chilengi, when he's available for this work. But we will just be team leaders, okay? Making sure that the people at Matero and the people at Machisopola are doing what you, the experts, have advised should be done. And then we need to report to you time and again, but we just have to make sure that delivery of at those places is meeting quality standards. Okay? And so as we move on, we need to have very, very strong community linkages. Strong community linkages are what we are looking for. So there will be awareness raised. As we said, these clinics are not targeted for this. These clinics are targeted at those who think they are well. Okay? And so the community must know that there's something happening now at Matero, there's something happening at Machisopola, which requires that us who think are healthy need to get help. And then we'll need obviously community-based volunteers to get involved in a lot more things. You can see what will be done there. Okay, we don't want people to be spending hours just waiting to have their height and weight measured. Hours waiting for people checked. No. We want these clinics to be very smooth running. Okay, someone should laugh me. Oh, yeah, I'll go to that clinic. He knows that within 10 minutes we'll be out. Okay. And to do that, we need to help use our volunteers. And then there's the issue of counseling, of course. Okay, counseling for risk factors. Okay, but you can see that I'm being very, very medical here. But we also need to really move towards getting people counseled about the indigenous knowledge systems. I think that is where the agenda was coming from. We want to ignore what these people do in their villages, which is not right. Some of the practices are helpful, but some of them are difficult to help. But we need to have counselors who can address those issues. Then adherence counseling is very, very important. Okay? And this is even of those people we think are educated. The other one was complaining. No, me, I'm taking the 20 milligrams. And you are changing me now to amlodipine 5 milligrams. Why are you reducing my dose? Okay? I said, no, I'm not reducing your dose. The two drugs are different. These milligrams mean different things to the two drugs. I think that, but there needs to be somebody who can actually find time to do that. Right now, our poor practices are because of time pressure. Okay? So we hope that, with the involvement of the nurses and the clinical officers, we will actually have a range of people who can help. And obviously, the issue of hospital follow-up, we have to use the same systems that our HIV colleagues are using to make sure that people are being followed up. And then, obviously, prudent use of diagnostics and drugs is very, very important. We will provide these clinics a limited supply of drugs, but the choice of those drugs will be cost effectiveness, which means that it's not really time for people to start misusing drugs. When suddenly drugs appear in a clinic where they have never been, sometimes there's a lot of excitement. Okay, and so everyone, let's go. Okay, it reminds me of some years back. When we just opened our private clinic, there was a company which was going to UTH. Okay, and so they were receiving just limited bills. Okay, because most of the times they would go there, UTH didn't have that, so they were getting very, very limited bills. Then there was a strike at UTH. So this company came to our clinic. Can we look after our patients? We said, well, much pleasure. And so when the patients started coming, they found that actually whatever drug you prescribe, they would get from the pharmacy. Yeah, they went and told their relatives, guys, drugs are available at St. John's. Let's go. So if you are coughing in the family, all of you come 8, each one with a bottle of cough mixture. Going home. Okay? But it was very, very expensive. So the company complained, hey, you guys, what's happening? You bring us 15,000 last month. This month is 45,000. Now it's at 80,000. Said, well, it's not us. It's the health seeking behavior of your people. Okay? So tell them to actually mind what is important and to try and use other means to try and address other things. So we are hoping that there will not be that type of, I shouldn't say misuse, but that type of excitement generated in those people. That now, let's all go down and get from there. Okay? But we hope that all will be well and that the communities will be well educated so that we have good uptake. Okay? This slide, I didn't want to read it at all. Okay, because this is about the processes of training. Okay, now we want to do good training of the health workers. Okay, but to do that good training, we ought to actually together specify the scope of their work. Okay, once we have specified the scope of their work, we come up with a training curriculum that is going to be used for the training, and we are going to examine these people and give them serious certificates. Okay? So we will be moving towards giving certificates of competence and not certificates of attendance. So if we want to say that this person is competent in providing care for rheumatic heart disease, what does it mean? That's where we want Dr. Sumi himself to have signed off saying, yes, what I want them to do at this level is this. If they know this, they are competent to look after my patients. Okay? That is your role, to try and define the parameters that we must go. And then the project management team is going to do it. Okay? So there are a few things that we are going to do as a startup. So in these hospitals where we are already sourcing for some laboratory test kits. All the clinics will have an echocardiograph machine, and all the clinics will have an ECG machine. So there will be nothing like you go to E21 to have your ECG done. Okay? ECGs and echo will be provided within the clinic facilities. And then we will have, as I say, a limited stock of drugs for priority NCDs. So those 10 NCDs we are talking about, we'll make sure that we have the minimum requirement in terms of drugs. Okay? And as I said, we are hoping that we'll have the automated system for keeping our records. So ultimately, what do we want to do? We want there to be improved community health with very, very much improved health outcomes. In that way, we are going to have fewer people suffering and fewer people dying from common NCDs. And this is what is going to promote universal health coverage. Thank you very much.
Thank you very much, Professor. Do you have any questions or comments?
I thought you were going to tell them that you are actually going to be the chair of the consultation. So this stakeholder consultation group will be chaired by the Assistant Director NCDs and Ministry of Health, because she is a major recipient of all that we are going to recommend. And once she agrees that this we are going to do, we are hoping that Ministry of Health will support it, but Ministry of Health are supported. We'll do a few things to start with, but we are hoping Ministry of Health will take over most of those things going forward. Okay? Right now, we're still debating, should we be doing INR measurements in these clinics? If the consultation group says yes, INR in every clinic, and she says yes, we will buy the first kits. But beyond that, Ministry of Health will have bound itself and have committed itself to buying the rest of the kits. Okay, thank you very much, Dr.
That's my first one.
Yeah, but does it matter?
No. I'm just wondering, what are some points doing?
Well, Maxomola is a very covers a very wide area. Yeah, goes down towards standard, the clinic is 150 kilometers away, and then there's a place called the Omo, which is at 180. Really covers the whole when that started. This is where it comes into view.
So if you look at potential or possible risk factors of the NCDs, do you think the people in that area are different from those in Ontario? Do you think they don't eat chickens? Chicken and chips? That's wondering, what I'm worried about is where, after a number of years, you don't see the difference. Say now you have to move to China.
We are hoping that we will find differences. Okay? Places such as Congo and their cities are very rare. But then people there are like, when it comes to physical activity, they walk outside. While people inside. So we're hoping to find that. But even there, you know, they are already doing motorbikes now. Okay? So motorbikes are so many people from cycling. They just jump on the motorbike. So there are issues.
Thank you, Professor Bono, for that presentation. My contribution is on training personnel in the project. Looking at the attrition rate in this country, it's quite high. So we need to have plan B in terms of finance of the personnel. Because if you certify a few people, 1 to 2 years down the line, they will no longer be there. Thank you.
Thank you very much. We already started talking to people, first of all, to reduce on, I shouldn't say attrition, to reduce on these people. So the initial group that we are going to train, we want to make sure that the people have agreed that at least for the next 3 years, these people will be lost in those things. Because we want to use those clinics as demonstration zones. So meaning that when you are training others, they can actually go to those clinics and sit with these nurses, sit with these clinical officers, and then put practices from there. So this issue of, today they are material, then tomorrow they are shifted to Chile, then the other day they are shifted, but I think that one will have come back in. We have already started talking. We have please talk to the medical superintendents in the hospitals, who will be part of the consultation group. Okay? Then we will be talking to the district medical officers who have already been appraised. And then at the Ministry of Health, the PS is himself the chairman of the ultimate team will be reporting. So we hope that he will support that policy. Okay.
Any other questions or concerns?
So the consultation, we internalized what is required. The question I want to hear your commitment beyond and saying, that's not what I signed up for. If you want to do beyond this, I'm not about it.
Maybe we can ask if all of you have received the letter. Have you all received the letter? Madam Wood, have we signed it? Maybe after this also. Or should we make them sign now? They might change their mind when they go back to UCH.
Those who have not signed, please see the government so that it's or if you are not available so as you all right, so now give us advice. Where should we start? The issue first of all of the gap analysis. Are you sure we are using science? Because the most expensive center, the most specialized. What do you want to be done at this point?
Thank you very much for the opportunity to include control of cancer in this project and hopefully eventually implementation. So for cancer, what I would like to see at first level hospital is awareness, early diagnosis. So for certain cancers, I want, for instance, for the healthcare worker there to be able to recognize the signs, make a diagnosis, and for some cancers to even take a biopsy and repair for pathology. And from there on, then they can repair to the next level of care for management. However, I would also like to see palliative care services at the district level hospital. And I would also like to see follow-up care and survivorship at first level hospital, where even after these cancer patients have been treated, they are able to be followed up at that level. They don't have to come all the way to the pharmacy to be followed up. And they are able to be helped throughout their continuum, rather than them to have to come all the time to the pharmacy.
Thank you very much. That we are actually ahead of that is manual. We define that this should be done, and then we say how can it be done. Then we give them the skills. Sure. That's the way. Okay?
Maybe we can ask Dr. Wire for mental health services.
Please.
I'm still trying to understand
So, take for example, in the first phase, so will it require us sitting as a team or as individuals and actually draft up all that's required in our specialty or area of care? Maybe can I just get feedback on that from me?
Yes, exactly.
All right,
Now, when we meet first time we meet, we will plan categorize which NCDs, which to obtain. So mental health will not be it as black. We want to have select conditions. Say these conditions must be looked for at primary care. Once they find them, they must sort them out.
All right, great. So when it comes to psychiatry and mental health, it's already disadvantaged compared to the other NCDs. A lot of us will appreciate that a lot of our general practitioners, medical officers, nurses in general, who are not specialized in mental health or psychiatry, already apply themselves when it comes to the other NCDs like diabetes, hypertension. Though when it comes to psychiatry and mental health, we've already seen a lack. And I think as a field, we've been trying to build capacity, and it's nowhere close to the other NCDs. So I don't know if there may be need, I think, for special consideration and maybe more efforts when it comes to the capacity building for psychiatry and mental health. Yeah. Thank you.
Exactly. I think that is the way we won't go one size fits all. If we say, diabetes needs 2 years for training, it don't be the same as mental health. But it is you to define. Say, for my people, this is what I need. And then for the training, obviously there will be 2 parts to it. There will be the didactics, which we'll do in the classroom, but there will be the practicals. Okay? And so for us to give them a certificate of competence, they must have done their own books. And so we are hoping that psychiatry, and then it will require them coming to work with other clinical officers in the clinics at China. Because what we want them to do in those clinics is exactly what those clinical officers are doing there. Okay? So that when they are referred to China, it's for specialized attention. There's something particular. But the basic competencies they must have. Now the question will be asking you is what are they? Okay? So you define them yourself. So when you say, shall we sit down and draft them? The answer is yes. Each one in their portfolio puts them out. So you say, for me, bipolar, this is what they should do. Say 1, say 2, say 3. Beyond this, let them settle. Okay? When you discharge them, you are confident to say, go and see the clinical officer knowing that they do exactly what you would have done. You see the thing? That's where we can.
Professor Bowman, yes, maybe I may be a bit theoretical. Do you have a Gantt chart for all those 10 diseases from the management team?
Yes, Gantt chart outlining all the steps so that it's uniform somehow for all the steps. We also say we start with training, give a period so that all the groups are following through.
Timeline. You have a rough idea of the big and one. But because we are not very sure when this meeting was going to be, we did not put in date. So now that the report will be launched, I hope that the boss will be here to launch it. Otherwise, Madam Sinumba will have to defer to side as CEO to do the launching. Okay? But whatever it is, we are here for the launch, so the document will be launched. Whatever it is, I mean, it just makes us get worried a bit that the boss is in a very, very serious meeting, because he had promised to be very, very quick. But obviously, it's not that quick, so there should be something serious happening. But now that we have had this meeting, the consultative group has been inaugurated, and so we need to put in dates, saying by this date we would have done the top 10, and then from there we give ourselves tasks. How do we address those top 10? Then from there, we'll have a few of our colleagues getting to do the training curriculum. But even after those drafts are done, the consultative group will have to sit and look at them and say, okay, this is okay, this you can use this for training, can use this for training. So it will be ticking at every stage. Yeah, so then after we know exactly what we are going to train, then we get the people to train. And then the clinics will be officially open. Okay, thank you.
Maybe I missed it. For a site like Matero,
Yes.
we see between 600 to 650 people in 24 hours, independent of the labor ward group, independent of the casualty group. So you find that the problems there, the nurses and the clinical officers are totally overwhelmed. And with two groups of patients, those who are coming in with an emergency, which is different from those who are coming in as if they are already taking drugs. So you find that even if you place 7 already existing clinical officers who will take shifts, they're already heavily overloaded. So within this development, you intend to send like 40 more nurses or 20 more clinical officers. Why I ask so is, in terms of the emergencies, the people who come in with emergencies, you literally see them, some of them seated on chairs, and they're trying to drop down the blood pressure, pray that it drops so that we can send the patient home. You see, it's very unusual way of handling issues. And those who have gone home, they are okay and they're going to come for review. There's no prioritization. It's going to fall in the same queue as those people who are unconscious until he can be seen. So that, in my opinion, among the things to be put in place, we try to factor in those. That, okay, if we're going to go to Matero, let's give them 20 clinical officers, 10 to handle the usual issues, and 10 to go on this path. Then there's a separate room to say, okay, let's now pay attention to diabetes and hypertension. There's an afternoon reserved for diabetes and an afternoon reserved for hypertension. Pray there are no students there, because the way it is now, if you go to that clinic, you find maybe 30 people, all of them deserve to be seen, but what you have is 14, 16 hours and only 2 afternoons. So as things are being put on the ground, it's nice to go and like work around there for a week to see how much work takes place there. So things can be put in.
When we were doing this, I think there was some that because NCDs don't have a particular place, we don't have many people for in that. And so we asked for 2 people to be given compliance. And then they couldn't get any people because of what we are explaining to us. So what they gave us was actually some empty space. So we have actually constructed 2 cubicles. But then, going through records there, we found that what is going on in the usual OPD, 80% is NCDs. Okay. So now really is the whole place which must be trained, so to say. So I think we'll move towards saturation. We try and make sure that all clinical officers, all nurses in OPD are trained. So we'll have to do it repeatedly until everyone is on board. Yeah. And then it's not only the ones at OPD, but we also have the ones who are admitted, So the nurses and clinical officers there also need to be trained. So we have a large portfolio to start with. Yes.
So can I suggest to perhaps help address the challenges that Dr. Nguyen and yourself have just alluded to, is to work with the management as well as the staff within the facility and try and implement person-centered care. So you talked about patient-centered care, but what I'm trying to allude to is person-centered care, where you will seriously sit down with the staff and their management to understand their barriers and facilitators to engaging in their day-to-day work. Because what we've found from a lot of our qualitative work is that, you know, as an individual, you come to your workplace with, you know, baggage from home, and then you come into the workplace and you find it constrained with so many challenges, the war zone that you described. But how does that staff member then still provide the services or the work it's supposed to do within that environment? So there are principles and approaches and theories and now training packages that you can work with to try and understand how you can change the dynamics as well as the culture for that institution. And we try to do it, not really at a large scale, but within certain facilities. And it does take training and mentoring almost to saturation all staff members working within the facility, starting from your security guards or your cleaners all the way up the chain to your MS. It's intensive, it's not exactly cheap, but it requires all hands on deck to actually start to change the dynamics in terms of how you can then improve the delivery of services despite working in a war zone.
Well, Dr. Direnda, you have given us extra work. But very, very necessary, because I personally that I was wondering, how are you going to go and work around this? You know? Because as far as that war zone remains, people will not be persuaded to come. You can imagine you want to have your BP checked, and you just enter the OPD as it is now. You get discouraged. You just walk away. You know? But there's something that we can do, and it's good to see Dr. Skazo saying it's possible for us actually to change the dynamics in that area. But it's a lot of work, and I think most says it has worked elsewhere, we will work at it. So probably before the clinic is open, we can start with this whole process. Because it's all just engineering processes from triage right up to the clinic. And I think it's doable. Thanks a lot.
Thank you very much. This is Dr. Chongo, public health specialist. So, appreciating very well that we will be improving on the treatment clinical care parts of our patients who will be presenting with NCDs. But I also wanted to find out to what extent this intervention goes with regards to prevention of these NCDs. So I know we may be treating, but we still have this stuff that we need to take care of.
Yeah, so on the prevention part, we are really hoping that the usual systems will keep in place, where we will be getting especially messages into the communities, trying to make them do right things. That's as far as we can go. This project is very much clear. So we will know a lot more when at hospitals, but we know that by the time someone comes to the hospital, things have already happened. Okay? To seriously get someone in hospital, please. Prevention has failed, so to say. So we are hoping that, you know, as we start on the other extreme, at the district level, we'll be using your normal systems to make sure that prevention is happening. And I think we have moved now, saying, apart from just behavior change, we also need to work on policies. And I think we will provide evidence for those policy changes. So we're looking forward to your unit to help us. I know you have a meat inspection team, but I think Dr. Jirenda was advocating for a juice inspection team also. Yeah, there are a lot of bad things on the shelves, and I think your team must just come into it. Must work, make sure that only healthy things are being sold to the public. Right now, we are in great danger. Yes, Dr. Wako.
Yes, thank you. I just wanted to follow up on his comment concerning the public health interventions for this, and I was thinking, I think the point that was raised earlier on the environmental health technologists and also the health promotion officers, including the CBBs, will really be very key and crucial in terms of prevention at community level. And once they're empowered, I think it is quite a good tool to use in terms of health promotion at community level. Like you said, we have more CBBs, even more than the frontline health workers at primary level, and I think those could be used, and they are very important and key in the prevention of NCDs.
Thank you very much. I should have introduced Dr. Marjorie Makula. That's part of the project management team. She's a medical educator from the School of Medicine Sciences at Unza. So she's the one who is behind this curriculum, because we want the certificates will be given to be accredited by both HPCZ and the General Nursing Council. So we will work at that, and there will be certificates that will come from Unza. So you can see how serious the certificates will be. That is why we need to train people well, but we must define what that wellness means. Yes.
I'm going to ask a question. What can our offer in this? Yes. One of the things that I haven't seen is data use procedures. I think that hasn't come out very well. So, for instance, I'll give you a very good example. About 2 years ago, our attrition rates were maybe like 20% of which are now they've fallen down to about 8%. So the question is, what did we do to reduce that? It's using the data. It's almost every week. So the procedures that you find in the facilities is those who are due for review the following week, a list is prepared prior to patients coming. A list is prepared for those who you expect to come for reviews. Calls are made, and those who don't come, within 24 hours, a list is again prepared by Smart Care. Identify those who are going to come, follow-up starts. So there's proper SOP. So that's continuous quality improvement cycle where you look at the data which come and then after. I think it's something that obviously it's expensive, areas and so on, but from the numbers that I've given, it does and budget implementation to that. So I think that's an issue. CQR part.
Yeah, thank you very much. We will be glad to know that when it comes to follow-up, we are using the same people we are using for ART, okay, in those 2 clinics. That is why we want the smart care system to be able to give them those lists as well. But we'll be using the same people, we will hopefully be using the same systems as well. So, Material, I think, has adequate staff in its data system. Polar was a bit short, so we have provided an extra person to look at that data. So what we want now is just the software to to help them do their work. So we have started integrating at systems level. And we are glad to note that, you are starting to work within the LRT clinics also to integrate NCDs. At least that will prevent people from moving from one clinic to another. They are getting their LRBs and they go to the NCD clinic to have their BP checked. Why? The health workers must be competent in both places to handle all issues. So we hope that that can be done.
Are there any more questions or? Yeah.
Okay, my name is Abdullahi Kariba, and just represents the community. I just want to find out if in the plan plus project you could also include like doing research on the NCE. And discovered that SCI is included. So, okay, so I discovered that STDs and STIs were included. And then I wanted to find out because my community has been having challenges in accessing some medicines to do with animal ones. And all that. So I wanted to find out how much we included in this.
Thank you very much. Others, we will not be deliberately addressing SCI, but the issue of what are the chronic condition, okay? And so they are worth talking about. And so it's good that they have been mentioned at this time. We'll try and see where they are among the 54 conditions. I think they are mentioned already. So we'll see where they land. If they are not the top 10, we will seek needs and ways of offering services. But if not, we will still make sure that people have capacity to address them. At least they have the skills and the knowledge to know exactly how to deal with them and point them to the correct place.
Thank you very much.
Just wondering how the strategy is.
Yeah, I think that's what was asking. We are going to need to set the dates for next week because we are not sure that this is today. Okay. So now that the meeting has taken place, we will communicate. Because as we say, it's very, very urgent that we get to the top 10 commission. What are going to guide how we move forward.
I know you don't have the dates, but maybe you can share the planned activities so they get a sense of what the activities look like very broadly, and then dates can be fit in at a later time.
Are we able to project our culture? Yeah, so this is the list of things that we have done. Okay? The whole list here. So not started, not started, not started. Okay? This is where we are going. Okay? So we are supposed to wait at initiating the clinical care model. That is the one that starts with the us defining the 10 conditions on which we will be working. Okay? And then we need to work on the baseline assessment tool. This one has been done. What we are waiting for is just collecting the information now and waiting for dissemination, which we say we will do when the team meets together to tell us what is required of those 10 conditions that we are going to work on. And then we will have these M&E tools that we need to put in place. Again, it has to be consultative so that we know exactly what we are monitoring. And this monitoring will be important. Okay? And then we need to now develop the trainings for frontline clinical and support staff. And then we move towards developing training centers in these two places, meaning that we would have defined a training curriculum, and we would have defined how we are going to train them. As I say, there will be those who need clinical attachments and those who want clinical attachments. Once that is agreed, then we will actually have a training plan. Okay? And then we will move towards well, this objective 3, to some extent, I think we have done most of that now. This orienting national level staff, including key stakeholders who spend plus. I think we have done this. Okay. Partly, we had, as we said, the global PI for the Pen Plus projects, Jim Bookman. He came to Zambia some 2-3 weeks ago. And so he met both the PS and the WHO country representative, and actually himself introduced the Pen Plus issue to them. But then they are the ones who gave us the letters of support when we are putting in the proposal. Okay, so for us to be granted this project, we needed letters of support from both PS and WHO country representative, and they gave us those letters of support. So when Professor Bookman came, he actually had a meeting with what we call the national level staff. So this one has been done. Okay. And then one national stakeholder meeting. This is the meeting that we are having today. Okay. And then we need to develop an approach and timeline for production of national operational plan, which is something that we are going to do as we move forward. And then we are reporting. So we have the activities. As I said, what we don't have the date saying by this date we should have done this, by this date we should have done that. But we are moving towards that. I hope I've answered the question. Dr. You have an idea. It hasn't been answered. Okay, thanks a lot. So this was okay. So this was our first attempt at putting dates, but you can see that we are running behind the rest. Okay. So we had to visit the sites. Mandela and Maisongola, we've been there several times now. So we know the places. Then we had to look at staff. As I said, yes, data based on, and the other one is what?
That's it.
Who's the food?
You've said everyone. Lab, clinical,
yes. Okay. So we did hire this staff, and then we are moving towards getting very involved as we start data collection. And then we are now in the process of getting what we call study supplies. Okay? The echo machine, the lab machine, and all the other issues they are actually being procured right now. We've had problems, of course, in trying to find what type of machine we are going to use. We, in a proposal, we had proposed one machine, but then Zambia is advising that we get a different type of machine. And so we got back to our lab team and said, okay, can we get a machine that, not complicate issues. So I'm sure we will get that machine. But as I said, the outlet will come from our description. What type of lab tests we want to have for the different conditions? So those will be the ones that will ultimately tell us what more we can do. And then renovations, cleaning setups, yes, I've said the material, they are building two people there, and they are using prefabricated materials. In my solar, we have to use pre-and-port, because the space we are building is outside. So there will be lots of rain soaking outside of the building. So we need two rooms in my solar, and I think they should have in the next 2 weeks. Okay? These trainings, this is what we need to adopt with, and make sure that we have the training materials developed. So this office standard operating procedures for training for all the people operators and the people that are going to and then study implementation. So study implementation, our initial target was focused. But as it is now, I don't think we will start focused because the training must be done before we start. So we are going to start with an aggregated training for the people who will these 2 clinics now. We are aiming to have a 2 weeks training. So we need to do all the 10 conditions in 2 weeks. Okay? Then they will get into the clinic and open the clinics. And then we'll train the other groups now slowly and do a deeper break, so to say. And those are the ones that we are going to give the NCD certification. So we are hoping that we will start before the end of the year. urging us that immediately the drink and water is done, and they have desks there, and their stethoscopes, they are ready to go. So we may actually hold on to that, and Minister of Health is talking of probably first week of August as open case. They will do everybody come and dance at the Don't worry, I've not changed. I'll do the man from the east. Okay? All right, any other questions?
Yeah, so the two have involved the stakeholders before procuring the equipment because visiting some equipment might be effectively like this, for instance.
We will be members for specific things. What we are doing now are generic equipment. Okay? As we say, we are the next right. And then, as I said, because INR, can we do INR? And will this be the same machine that we do INR? Or shall we get testing for INR? Those are the questions we ask the particular stakeholders.
That's why I was asking because you might be able to get a machine that's at a lower cost that can do multiple things versus you procure one for you and you like just an example. You need to procure for electrolytes, you need to procure like maybe the echo machine can also do ultrasound guided biopsy, but then because you already procured the echo machine, you need to buy another ultrasound for guided biopsy.
That is why we are looking for this meeting, and we are looking for those who actually accept our invitation to sit in the consultation. So we haven't brought them as yet, we are still consulting. So I think we are just in time, that is why our first comprehensive meeting has been soon, rather than later, so that we can actually initiate this process. Alright, so I think my debate has ended here. May I ask Dr. Smoga to please take over? So perhaps before she comes on, as we go forward today, for this statement, we can have properly introduce ourselves. Slowly, we want to move we say, and go and ask. What do you need to be done with it?
My name is Elijah Ngoma. I am from the Spanish Congo. Good afternoon. My name is Mike Mogala from Zambia NCDI. I'm a journalist. Thank you. Good afternoon, everyone. My name is Alexander Samba. Good afternoon. I'm Rafa Mendes. Police people in the
I am Nidhi Soko from the Zambia Cancer Society. I'm the founder and executive director. Good afternoon. I'm Susan Chitambe Zanaba. I'm an oncologist. We all know what an oncologist is. Okay, an oncologist is a cancer doctor. So I treat cancer with chemotherapy and radiotherapy. Good morning, everyone. My name is Mary. My name is Mary. I work for the local organization.
Good afternoon. My name is Dr. Soda Nyoka, physician and litigator. Good afternoon. I'm Michael Italia for the University of Zambia School of Basic Sciences. Good afternoon, Francisco Maria, psychiatrist, for mental health hospital for Good afternoon, my name is Dr. Antonio, public health specialist in South Province.
Good afternoon. Good afternoon. My name is Carol Martin from Italy.
Afternoon. My name is Abby from English. Thank you.
Good afternoon. I'm Executive Director. I'm from the NCDI community.
Afternoon, everyone. I'm Milanani from Silence Medical Center for the Universe. Good afternoon, Miss It's an English
Good afternoon, everyone. My name is Amanda Thomas Nani. I'm a research profession and a scientist.
Good afternoon. I'm Mwenge Mlenga, Communication Officer, Silence.
Good afternoon. I'm Dr. Taye, Research Commission Service. Good afternoon, everyone. Someone also brought that I need analysis department of science. Just to add, the name like that in science is like my choice.
Good afternoon.
Good afternoon. I'm Good afternoon, everyone. Good afternoon. I'm Boston. I'm from Art. Good afternoon, everyone. My name is Robert Santoto from Science Communications.
Good afternoon, everyone. My name is Robert from University. Good afternoon, everyone. I'm Super from Communications. Good afternoon, everyone. I'm Professor China from Davis.
Good afternoon, my name is Stephen from Science.
Good afternoon. My name is Nancy from Oxford.
Good afternoon. My name is Manyanga from Upton, Zambia.
Good afternoon. My name is Francesca Savannah from Oxford.
Good afternoon. I'm Winfrida Kambuya, my leave from Zanis. We need news so that we go and get it and put it on TV. Please.
I know, right? To avoid this country, I think it's quite disrespectful. That's happening. Oh, it's good. So what are you doing? What is your role? The title doesn't say anything. That's part of it. Right? I think you've got no way to say it. This is not the black yeah. But one of the questions I did oh, true. With the light, but it's just so I'm a research commission. Like, the title because I want to go to the research. I can find myself there. So I found myself in this NCD space and discussion. So my project is now NCD that we have but as I go forward, I think I'm going to tailor it more to the action side. Yeah. Yes. So, I think it's the big one and getting to learn quite a bit. Yes. Yes, I do. Yes. Yeah. So I still have to find time to check the samples, work hours, weekends, sort of continue on. Yeah. So I don't do that. Yeah. Hope together probably in the next 2 or 3 years. Yeah. Who knows? Maybe one day I will. Yeah, but I guess that's actually the direction of the health world NCDs. Find the space there. And I went to yeah. I mean, not more.